disease. And I think the stenosis is secondary to the fistulizing, or the fistulas there. So, I think in those situations that we probably can't eradicate it, and we would probably do what you do here, and that is do an EUA, unroof fistulas, put in cetons, maybe give them infliximab, and see how they do. So that would probably be our approach to it.
Do you feel from the results of this randomized trial that the hypothesis of stasis above the anastomosis has been disproven?
No, I don't think so. This trial that we did, being a little bit of a clinippy nerd that I am, it was, I thought, a really interesting study because Bruce Wolfe from the Mayo Clinic was the other principal investigator on it. And as everyone knows, there needs to be equipoise if you're going to do a clinical trial. There isn't usually equipoise in the investigators. And Bruce felt very strongly that the type of anastomosis made a difference. And I felt equally as strong that it didn't make a difference. So it was a pretty unusual situation for the two of us to have different views on it. And why I don't think that we've answered that question, Peter, is because way back in the dinosaur age, when I was a surgical resident, we actually did surgery for peptic ulcer disease. That our boss, Bernie Langer, when we did gastrojejunectomies, and we'd say to him, how big should the gastrojejunectomy be? And he'd say, well, it doesn't really matter, because if the anastomosis is this big, but the jejunum, the width of the jejunum is this, that essentially is the size of the anastomosis. And so I think that's why I didn't really think that it was going to make a difference, because if the anastomosis, is that big and the ileum or the cecum is that big, that is essentially the diameter. So I think, I think that, something's going on there, I think, and that there, as we were discussing, that I think it may be a motility disorder, or just interruption of motility. I don't think it's mechanical.
You don't have frozen samples or stool samples from your study, do you?
No. We tried to do that actually, but we had 17 centers that were participating, and to get that through the IRB of 17 centers, finally we just said, oh, forget it. This is too painful, which is too bad.
I would like to say I agree with you completely that
that's because you're a dinosaur like me.
If you hadn't said what you did, I was going to say it doesn't matter how you put it together. It's only an end-to-end is not necessarily bigger or smaller than side to side. Once you get all finished with it, it ends up looking about the same.
Well, for this,
and there may be some motility issue. I mean, you're taking out stuff and sewing it together. Who knows?
For this study, we actually got 100 millimeter staplers from Ethicon. So we really tried to, make it as big as we could,
but when you go back a few years later, it's all.
Oh, I agree.
If you're not operating for Crohn's disease, you just happen to be there for something else. It's all shrunk down.
Right.
And a lot of that shrinking down is right at the staple line, too. All the time, particularly if there's ongoing inflammation and ulceration from Crohn's disease right around there.
We all have preferences in this. I virtually never staple these things. I always hand sew them, but I don't know that that makes a difference.
Yes?
It's for those high-risk individuals who we believe, as best we can tell, may have likely further strict-strain disease, where we'll often argue for the use of biologics as maintenance following surgery. In your experience, what do you think about the timing of when, in your own experience, to begin biologic therapy after that?
Well, I guess the first thing I'd just question you on, who are those individuals that are at high risk for developing stricturing disease? How do we identify those?
We don't have a great way to identify them, but certainly those are the ones who multiple surgical revisions geography where they haven't responded to other agents.
Yeah, fair enough. When do we start them? Well, it's not in my control because I'm not a gastroenterologist, but they would start them, I guess, probably a few weeks after surgery, I guess. Not immediately after, if that's sort of the
We
question.
seem to have the pendulum swinging toward treating people post-operatively now with some kind of preventive therapy as opposed to not. But I guess in your view, it's just still kind of up in the air. I know I have several patients now that are post-op saying, well, when are we going to start whatever it is in your hand, or put some ab, and I say, well, I have to make sure they're not going to get an abscess and they're healed up and all that kind of stuff. Juggle with that. But it's a little bit discouraging to hear you say it doesn't make any difference or we don't know.
Well, I mean, it's a fundamental question of surrogate endpoints versus the endpoints we really care about. And the surrogate endpoints are endoscopic healing, if you believe Paul Richard's data, is that flagell after surgery and azathioprine are helpful for endoscopic outcomes. The actual proof that it changes clinical outcomes is pretty soft because you haven't done it. No one's done a 5-year trial or a 10-year trial.
But biologically, if you look at the biologic sense of it, I think more and more the trend is to believe things like the endoscopic appearance and the inflammatory burden on studies like CT enterography and things like that because it makes such biologic sense based on what we know about the.
Yeah, but I don't know whether, if say this is the endpoint here, and whether you're moving with whatever maintenance therapy, you're moving it to this, or whether you're just moving, yes. And I think also that, and this is what I've learned just a little bit, is that, in arthritis, that now that there is some evidence that giving medication to decrease the progression of osteoarthritis, that now there's a belief that it's just really treating the symptoms. And I think that's the other thing, is that are you really changing the time course, from when they develop symptoms to that you're just really sort of probably treating that inflammation. So I don't know about that, Ellen. I'm not convinced that we're really moving it out, and I'm also not certain that I think, as Ryan said, that I think that I can't, as I pointed out, the studies that we're doing it on maintenance therapy are patients who have terminal alveolar disease where all the disease is gone, but there's certainly a subset of patients who've had multiple operations, multiple sites, and and those, I think that everyone would agree, even though the evidence isn't strong, that they probably should have maintenance therapy. But I'm not sure that the patient who has a terminal ileal resection or ileocolic resection, and say that the endpoint is their second operation, and that you move it, say, from 5 years to 5.5 years. Is that really worthwhile? So I think there are a lot of questions, and why I say that I want to be on the side not against gastroenterologists or medications. I put that up that I did do a study on 5-SA, so I'm interested in this question, and I'm sort of in there with you, and I'm not trying to say that there's no role, but I do think that looking at endoscopic recurrence, looking at it at 6 months, and then looking at the patient preferences, giving them medication, are they going to be compliant with it? Do they think it's important? I think there are a lot of important questions. And it's a hard area.
Thank you all very much, and please fill out these green forms.